take wear tu.
Acah, dia tahu jelas tapi dia nak cakap.
Saja
Jelas
lah.
sebab dia ada take wear.
Tanya. Jelas.
Weh, je lah.
Mantap saya. Tak wear.
Okay, kita start.
Dengan cerita dia mat baru.
Wish. Matt.
Mantap saya.
Mantap doh.
Mantap saya.
Adi doh mantap.
Adi tu.
Adi, bila nak belanja aku mat RGB lah.
Sedap kot, boleh menang kot dengan Matt ni.
Mantap.
Okay. Gerak.
Right. Yeah.
So kita akan bincang about Pediatric Hydrocephalus. So during my first neurosurgical clinic to this before, aku punya first patient, second patient, third patient semua adalah hydrocephalus. So apa?
Record.
Share record
Boom.
Right. Boom.
Okay. So sebenarnya kita kena tahu normal basic things dulu. So cerebral spinal fluid CSF found in ventricles and subarachnoid space of brain and spinal cord. I think you guys tahu ni dia formed by choroidal plexus, okay, reabsorb into blood circulation through arachnoid granulation dekat arachnoid metal lah kan, between pia metal and also arachnoid metal dia ada granulation. So dia akan reabsorb dekat situ. Okay, clear, colorless, contain glucose, protein, lymphocyte. Right. Okay, so ni kita punya pathway of the ventricular system. So mula kita nampak lateral ventricle, choroid plexus of lateral ventricle, dia akan go through the third ventricle, passing through the foramen of Monro ataupun interventricular foramen. Bila dia masuk situ, dia akan travel to cerebral aqueduct. Okay, dia akan travel to that aqueduct, then to the fourth ventricle. Fourth ventricle pun ada choroid plexus, third ventricle pun ada choroid plexus. This untuk ni lah produce CSF. So bila dia dah sampai dekat fourth ventricle, okay, dia akan either masuk dekat foramen of Lashkar atau Megendie, okay, untuk dia travel back to the subarachnoid space and reabsorb into the venous system lah. Okay. So ni anatomy of brain, CT brain. Kita kadang masa mula aku tengok CT brain aku tak tahu apa benda aku tengok ni. So this is CT brain. Kita boleh tengok patient ada lateral ventricle yang on left side of the laptop. I mean the screen ni kita nampak ni. Dia ada this is the lateral ventricle. Okay, bawah ni kita ada third ventricle. And bila kita scroll down bawah sikit kita boleh nampak lagi jelas this one, fourth ventricle. Okay, dia depends on the location lah. That's why kita kena scroll CT scan tu. Okay, bila kita nampak lateral ventricle, third ventricle and then lastly kita nampak fourth ventricle. Okay, usually patient yang hydrocephalus kita tak akan nampak dia punya temporal horn of the left lateral ventricle lah. Mana aku ni? Okay, ni lateral ventricle, ni frontal horn of the lateral ventricle. Korang kena tahu lateral ventricle ni ada frontal horn, occipital horn and temporal horn. Usually dia tak akan nampak occipital and also temporal horn. Tapi in hydrocephalus dia akan nampak benda tu. Nanti kita tengok okay. So this circulation of CSF. Macam tadi lah sama je. Lateral ventricle to third ventricle, masuk fourth ventricle, and then to subarachnoid space, dia akan reabsorb through the arachnoid villi and then to the sinus, eventually to the venous system lah. Okay, kita nampak tu CSF is mostly reabsorbed into the venous system through arachnoid villi. Nampak gambar ni, dia arachnoid, bawah durameter, arachnoid meter. Okay, atas pia meter and bawah arachnoid ni kita ada trabecular. Okay, nama lain dia yang panjang ni adalah villi dia. So mostly this villi akan, this villi dia akan travel back to the venous system. Dia akan reabsorb the CSF and then travel back to the sagittal sinus. Alright. So function of CSF ni adalah untuk cushion and protect CNS from trauma. And dia akan provide mechanical buoyancy, support for the brain. Okay, dia reserve as a reservoir. Okay, nourish the CNS, remove metabolites. So definition of hydrocephalus is is a disorder in which an excessive amount of CSF accumulates within the ventricles or subarachnoid space, resulting in ventricular dilatation and ICP. So the key word is excessive amount of CSF and ventricular dilatation. And ICP ni tak semestinya dia akan cause ICP, sebab in patient yang neonates ataupun infant, sutures dia tak completely tutup lagi kan, dia akan open. So bila dia open, dia still boleh, brain boleh still besar, dia boleh growing lagi. So dia akan prevent ICP lah. Dia akan prevent increase intracranial pressure. Tapi in patient yang dah adolescent, young children, dia akan tutup suture dia and cause increase ICP. Tak semestinya ICP lah dalam hydrocephalus, but keyword dia amount of CSF and also ventricular dilatation. Causes dia kita ada 3. Okay, obstruction, either obstruction to the flow of CSF or overproduction of CSF or failure of resorption of CSF. Okay, korang kena tahu macam mana nak classify, sebab the first question yang doktor tanya aku is how you classify the hydrocephalus. So dia ada communicating, nampak ni? Ni etiology, kita tengok classification dia. Communicating as a non-communicating. Communicating is non-obstructive and non-communicating is obstructive. Okay, usually tengok etiology dia, primary and acquired. Dua-dua ni boleh cause dua-dua ni lah. Okay, primary boleh cause obstructive, primary juga boleh cause communicating ataupun non-obstructive, acquired pun boleh cause obstructive and acquired pun boleh cause non-obstructive. So depends on the etiology. And kita boleh tengok on etiology dia boleh cause communicating ataupun non-communicating. So contoh for example ni, obstruction of SCSF flow. Ni adalah non-communicating lah kan, sebab dia obstructive, non-communicate. Dia tak boleh communicate to ventricles. So obstruction of SCSF flow. Common obstruction occurs is at aqueduct sylvis, yang from third ventricle to fourth ventricle. Dia akan selalunya ada stenosis kat situ. Foramen of Monro, fourth ventricle and its outlet. Okay, either to the foramen Lashkar ataupun foramen Magendie. Okay, usually obstruction of CSF flow ni akan cause dilatation of the ventricular system proximal to the obstruction. For example, patient yang ada aqueduct stenosis dekat sylvius aqueduct, okay, dekat atas fourth ventricle tu, dia akan cause lateral and also third ventricle dilatation sahaja. Dia tak akan cause fourth ventricle dilatation. Sebab apa? Sebab fourth ventricle tu tak obstructed pun. Dia boleh produce lagi, dia punya CSF and dia masuk balik aeronac villi to reabsorb. But then yang kat atas tu, dia tak boleh nak flow to the fourth ventricle sebab ada block dekat aqueduct itulah sylvius kan. So dia akan cause obstruction and cause dilatation of the ventricle semua tu. So that's why dilatation of ventricle system proximal to the obstruction. Okay, number 2 is impaired absorption of CSF. This is typically due to inflammation of the subarachnoid villi lah. Okay, that may be caused by impaired CSF absorption or increased pressure. Okay, the hallmark of communicating ni ataupun non-obstructive is dilatation of entire ventricular system, sebab dia akan cause diffuse dilatation. Dia akan, sebab dia bukan ada obstruction, dia impact absorption, maksudnya dekat third ventricle dia dah susah nak absorb, dekat lateral ventricle susah nak absorb, dekat fourth ventricle pun susah nak absorb. So eventually semua akan dilatation of the ventricular system. So contoh dia, contoh dia macam, okay, nanti kita tengok. Okay, overproduction ni paling rare lah, okay, paling rare. Contohnya adalah coronal plexus papilloma. Dia paling rare, tak kena. Okay, leads to enlargement of the entire ventricular system. Sama macam ni lah, impaired absorption of CSF. Okay, impaired absorption of CSF, contoh dia macam ni, macam meningitis, yang inflammatory punya causes, yang boleh cause impaired CSF absorption. Nampak ni, ni contoh-contoh dia. Kalau obstruction, yang most common is malformation, Arnold Chiari ataupun Dandy Walker. Ataupun any
Arnold Chiari bukan ni herniation lah.
Herniation.
Lepas tu Dandy Walker apa? Tengok.
Dandy Walker nanti kita tengok macam ada.
Alright.
Boom. Okay, nampak tu aqueduct sylvius pun ada one of the cause of obstruction CSF pathway. Overproduction CSF ni macam kita cakap tadi, papilloma. Defective reabsorption macam post-infectious or post-hemorrhagic destruction of villi. Semua tu. Right. Okay, number 1 kita tengok Arnold Chiari formation. Sebab this is one of the most common congenital problem, okay, yang boleh cause hydrocephalus. Okay. Dia affecting the structural relationship between cerebellum, brainstem and also upper cord, cervical cord and bony cranial base. Kita boleh classify dia based on the imaging lah. So number 1, type 1, it's more than 5mm descent of the caudal tip of cerebellar tonsil past the foramen magnum. Okay, nampak yang nombor 1, nampak atas ni. Dia tonsil dia ada displacement only more than 5mm descent je. Okay, past the foramen magnum. Dia maksudnya a part of the cerebellum akan masuk dekat foramen magnum, cause obstruction. Okay, usually dia tak ada obstructed lah. Usually dia boleh flow je lah through the masuk dia boleh masuk dekat aeronac villi. Tapi due to the obstruction, dia boleh cause dilatation, then dilatation of the ventricle lah. Okay, that's why boleh dapat hydrocephalus. Type 2 yang belah kanan kita, yang atas ni, is due to brainstem, fourth ventricle, and also more than 5 mm vermis herniation plus lumbar myelomeningocele. Dia ada lumbar meningocele, maksud spina bifida. Okay, dia ada brainstem, also fourth ventricle, and vermis herniation. Maksudnya brainstem, dia pun brainstem, fourth ventricle, and also vermis tu, dia boleh masuk dekat foramen magnum, causing obstruction. Disebabkan ada spina bifida tu. Okay, due to mass dekat bawah tu, dia boleh kadang, logically dia boleh tarik lah sebab dia ada mass kat bawah tu kan. Dia boleh tarik some of the vermis, some of the brainstem, and some of the fourth ventricle, causing hydrocephalus. Type 3 is cerebral herniation into posterior encephalocele. Maksudnya dia ada memang ada development, mal development of posterior cranial fossa. Tiba-tiba ada encephalocele belakang tu. Dia ada lubang yang boleh cause brain to herniate dekat belakang tu. So maksudnya bila brain dah masuk belah situ, dia akan cause obstruction lah. Okay. And then number 4 is cerebellar agenesis. Dia tak ada cerebellum. Dia hanya ada di bone belakang tu, and then also brainstem, and also itulah, itu saja. Dia tak ada cerebellum. Okay, carry type 1. Ni aku dah cerita banyak. Ni sama macam tadi, 5 mm cerebellum masuk dekat foramen magnum. Dia takkan produce symptom sebab dia sikit saja. But yeah, if in symptomatic patient associated with spinal syringomyelia, this is a fluid filled cyst. Ni tak payah tahu kot actually. Spinal hydrocephalus. Carry type 2 is macam tadi, yang 4 benda tu, fourth ventricle, medulla, cerebral vermis, masuk dekat foramen magnum. Okay. So patient yang nampak okay, tu je lah. Disebabkan dia ada lumbar myelomeningocele, spina bifida, dia boleh tarik semua part of the brain tu masuk ke foramen magnum.
Ni most common ke apa?
Type 2 is most common. Type 3 malformation sebabkan ada lubang bawah belakang tu, so boleh cause encephalocele. Cerebellum masuk kat situ, and then dia tarik a part of brain kita dekat bawah tu, and then cause herniation, cause hydrocephalus. Dia obstruction of the CSF flow. That's why ada hydrocephalus. Dandy Walker ni is a rare, but then I think doktor pun kadang banyak cakap, tanya kat ni. So involve the cerebellum and fourth ventricle. It is characterized by agenesis or hyperplasia of the cerebellar vermis. Ni macam yang number type 4 of the carry malformation lah, dia ada agenesis. Okay. Bila ada agenesis or hyperplasia of the cerebellar vermis, dia pun ada cystic dilatation of the fourth ventricle that blocks CSF from exiting the brain. Maksudnya dia ada cystic dilatation dekat fourth ventricle. Tiba-tiba dia ada cyst kat situ. So bila ada cyst tu, from third ventricle nak masuk dekat fourth ventricle tak boleh, nak obstructed. Then dia boleh cause hydrocephalus. Okay. Danny Walker ni comprised of dilatation of lateral and also third ventricle. Sebab apa? Sebab dia punya problem tu dekat fourth ventricle, dekat cyst, atas fourth ventricle tu ada cyst. So dia akan cause dilatation of atas tu. Dilatation of the lateral and also third ventricle. But lesser extent than the fourth ventricle. Widely separated like hypoplastic cerebellar hemisphere with a small number, ni tak tahu lah tu. Cystic dilatation of the fourth ventricle sebab ada cystic dalam tu. Okay. Pathophysio of hydrocephalus. I think korang tahu ni. Production of CSF, contoh ada block, okay. Overproduce, reduce absorption, cause ICP increase. Bila ICP increase, dia akan compensate transventricular absorption. Dia akan pergi laluan lain untuk absorb the CSF. Tapi bila dah banyak sangat, okay, dia boleh cause enlarge, dia akan cause frontal and temporal horn dilate. Bila dilate banyak sangat, elevation of corpus callosum, enlargement of third ventricle downward to pituitary fossa, and then lastly boleh cause dorsal midbrain compression, Perinox syndrome. Yang Suhail present itu, paralysis of up gaze, nystagmus, sebab dia ada compressed to the midbrain lah. So midbrain kita tahu yang kita ada banyak benda kat situ, cranial nerve semua tu, boleh cause paralysis of up gaze and also nystagmus. Okay, so clinical features dia depends. Okay, depends on the timing of onset, the duration, and also presence of structural abnormalities. So nombor satu kita tengok timing of onset. Relative to closure of cranial suture. That's why I cakap tadi, if hydrocephalus develop in infancy prior to fusion, sign of SCP may be absent or mild sebab dia buka lagi. That's why dia boleh cause growing of the brain. Dia dia tak ada obstructed. Maksudnya dia tak terkurung dalam tempurung tu. Sebab suture dia still boleh buka. So dia boleh relieve pressure lagi lah. The most common presenting complaint in this population is enlarging head circumference je. Kita buat head circumference kat baby tu, mungkin ada enlarging. And then when patient develop in older children, neurologic complaint and symptoms of ICP are more common like vomiting, nausea, headache semua tu boleh dapat. The duration of rate of ICP increase. Macam tu. Rapid progression of ventricular dilatation results in early development of symptom. Okay. Presence of hydrocephalus symptom yang macam infant and children with hydrocephalus caused by ada tumor ke may present with focal neurologic signs rather than ICP symptoms. So kau kena tengok, kau kena pandai. Depends on these three things. So infants usually vomiting. Okay, eye gaze pointed forward due to the besar sangat tak dia, kepala dia tu. Dia akan cause pressure lah to the eyeball kan. So eye gaze pointed downward. So ada lid retraction semua tu. Progressive weakness. Okay, ini kalau dia dah cause ni lah, focal neurological deficit, spasticity kan. Poor feeding, failure to thrive, delay development milestone, nystagmus. Kalau childhood, ICP symptom macam headache, nausea and vomiting. Okay, visual disturbance, nystagmus, semua adalah cause compression of the brain tu, boleh cause midbrain kan problem. So ada visual disturbance, nystagmus. Alright. Okay, ni clinical features ni dalam buku neurosurgery tu. Kalau acute onset patient untuk infant and young children ada irritability, impact conscious level and vomiting. And for grown ups lama-lama dia boleh develop mental retardation, failure to thrive. So usually yang patient aku nampak tu, young children lah, dia memang ada mental retardation. Bila kita panggil dia macam dia tak ni. Kalau kita cakap hi pun dia macam pandang ni tu. So due to compression of the brain content, so I think make sense lah patient ada mental retardation. And then crackpot sound, okay, on skull percussion. Ni semua sign lah, symptom. Sign dia. Increased skull circumference, lid retraction, impact upward gaze from pressure. Okay. Setting sun appearance lah. Okay, mata dia kat bawah tapi dia punya eyeball tu buat sklera dia kita boleh nampak daripada atas sampai ke dia punya mata hitam tu. So ada lid retraction, setting sun appearance. Macam sunset lah kita kan. Kalau juvenile or adult type, acute onset ada ICP symptom lah. Okay. Sebab suture dia dah tutup. So ada headache, vomiting, papular edema, okay, conscious level impact. Gradual onset mungkin dapat dementia, gait ataxia semuanya. Ni lama-lama lah. Okay. Clinical features of akidak tak payah. Okay, investigation apa kita buat? Paling penting is neuroimaging. Sebab neuroimaging is the diagnostic feature tool for hydrocephalus. Maybe sign, clinical pun boleh nampak lah patient kepala besar. Okay, mungkin this is hydrocephalus. But then for diagnostic tu kita kena pakai neuroimaging juga. Lumbar puncture ataupun measurement of ICP. So number one is ultrasound. Ultrasound is usually kita buat masa antenatal care lah ataupun postnatal care yang within 12 to 8 months after birth. Okay. Okay. Insufficient for primary diagnosis use but useful for serial assessment of ventricular dilatation. But usually patient kita akan pakai MRI or CT scan. Use the diagnosis of hydrocephalus. So most reliable sign differentiate ventricular enlargement due to white matter atrophy. Okay, sebab white matter atrophy ni kalau korang baca dia sama juga signs. Dia sign dia macam sama from hydrocephalus, dia ada dilatation juga ventricular tu. Tapi mungkin kita pakai MRI or CT scan kita boleh differentiate between these two lah. Okay, nampak okay, A dia ada MRI, kita boleh nampak ada transepidermal flow. Okay, kejap ni arrow ni nampak. Dia kecil-kecil atas ni disebabkan dia ada ventricular dilatation. Tapi disebabkan banyak sangat dilatation of ventricle ni, so some of the fluid akan cause edema dekat depan. Dia macam flow lah, dia macam pecah masuk dekat brain parenchyma. That's why dia ada macam hypodense lesion dekat atas kecil-kecil. Sebab dia terlalu dense, so boleh pecah masuk kat brain parenchyma. Kalau B ni sama juga lah. Ada enlarged frontal and also occipital horn. Mana arrow tu? Ni frontal horn. Ni occipital horn kita. So dilatation.
Contohnya hospital tak nampak kan?
Kita nampak, memang tak nampak. So memang ni hydrocephalus lah. So C ni CT scan yang show bentar ya. D tu apa? Okay. Nah ni doktor aku cakap ada apa kriteria CT scan. Tapi tak tahu lah. Dia cakap pun dia bukan level kita sebenarnya. Tapi aku letak lah kot. Sebab contoh size of both temporal horn ni is greater than 2 mm. Clearly visible. This is one of the criteria for acute hydrocephalus. Sebab nampak in the absence of hydrocephalus, the temporal horn should be barely visible. Okay, patient yang ada temporal horn greater than 2 mm, kita mungkin boleh cakap di patient ni memang ada hydrocephalus. Ratio of largest width of frontal horns max to maximal BPD greater than 30%. Maksudnya frontal horn ni, dilatation dia, lebar dia is greater than 30% compared to the maximum BPD. Maksudnya BPD kan. So frontal horn tu greater than 30%. Sepatutnya dia tak ada lah, dia tak ada dilatation lah, tapi greater than 30% in hydrocephalus. Transabdominal exudate ni macam tadi aku cakap, dia ada flow, transabdominal flow. Okay, dia nampak ni, periventricular hypoattenuation. That's why kita boleh nampak hypoattenuation ataupun sini macam ada hypodense lesion ni kat sini. So itulah apa flow tu, transabdominal flow. And then ballooning of the frontal horn of lateral ventricle and third ventricle, Mickey Mouse, that may indicate aqueductal obstruction. Sebab apa fourth ventricle tak affected? Sebab dia atas fourth ventricle. Sebab macam aku cakap tadi, aqueduct stenosis tu dekat atas fourth ventricle kan. So fourth ventricle tu tak affected. Dia hanya affected lateral and third ventricle yang boleh cause Mickey Mouse appearance. Ni lah Mickey Mouse appearance dia. Kita nampak ni adalah frontal horn. Ini adalah third ventricle. So that's why patient dia macam nampak Mickey Mouse appearance lah. Padahal temporal horn pun dilated juga kan. So kau mungkin boleh nampak ni as a Mickey Mouse appearance. So may indicate hydrocephalus. So lumbar puncture ni is not necessary for diagnostic evaluation sebab dia contraindicated lah if patient ada tumor ke intra ataupun intra space occupant lesion, memang tak boleh sebab boleh cause herniation. So neuro imaging should be performed prior to LP. Mungkin sebab kita nak tengok what are the causes lah lumbar puncture. Lumbar puncture kita tengok what are the causes of hydrocephalus. Mungkin meningitis, encephalitis semua tu. So measurement of ICP ni is a surgical placement of ventricular or intraperitoneal pressure transfer. Usually kita buat ni dekat OT lah. Kita letak insert. Kita letak nama dia ICP probe. PROBE. Kita letak situ, kita boleh calculate ICP. Ataupun senang pakai lah lumbar puncture kan. Kita boleh tengok opening pressure tu. Provided there's no intracranial lesion. Okay, nak tengok either ICP is elevated or not. So management dia kalau acute, nampak in cases of rapidly progressive hydrocephalus, symptomatic semua tu, kita memang kena letak drain, EVD. Meaning dia until permanent shunt can be placed or until the hydrocephalus resolve. So kita letak EVD ni either sampai dia okay ataupun kita memang plan nak letak shunt. Okay. Medical treatment pun boleh juga, like diuretics. Contohnya lah acetozolamide. Okay, in patient yang kita pakai glaucoma tu kita pakai acetozolamide juga kan. Tapi in hydrocephalus pun boleh juga aku baca sebab choroplexus ni is macam mana dia boleh produce CSF is by carbonic anhydrase. So acetozolamide tu adalah carbon anhydrase inhibitor. So bila kita inhibit that anhydrase, kita akan impact CSF production. So that's why kita boleh pakai acetozolamide. Okay, serial lumbar puncture okay, symptomatic and high respiration. About surgical intervention is indicated if patient has symptoms, progression of ventriculomegaly on imaging, clear obstruction. So these are the three main thing yang korang boleh tengok before kita buat surgical intervention. Okay, if patient ada headache, vomiting memang kena buat, atau focal deficit lagi lah kena buat kan. Progression of ventricle tu besar, kita buat clear obstruction. So kalau asymptomatic or low risk, kita just buat serial hip measurement, assessment of gross motor skill. Okay. MRI CT is preferred lah for follow up kalau ada clinical concern semua pun. Okay, ni contoh lah ventricle VP shunt. Okay. Banyak patient yang jumpa dia ada VP shunt. And doktor suruh kita palpate ni, nampak belakang. Memang kita akan rasa dia macam tube kan. Bila kita pegang tube ataupun kita pegang wire sekarang kita pegang wire, kita dapat rasa tu. So dekat belakang patient tu kita dapat rasa dia shunt. So basically inilah contoh dia VP shunt. This is kita ambil wire ni is from ventricular and then kita letak dekat peritoneum kita. So all the ventricular tu akan drain into our peritoneum. That's the concept lah. Okay. And then endoscopic third ventriculostomy ni tak sure, tapi one of the ni lah what way of kita nak drain the ventricular system. Okay. Yang selalunya ni EVD ni pun common juga. Ini for temporary lah, sebelum letak shunt. Okay, kita letak wire ambil benda, lepas tu letak kat chamber and then drainage back for CSF. Sama juga. But this is for temporary dia, EVD, external ventricular drain. Alright, that's it boys.
Cheers lah.
Mantap lah.
Okay kan?
Okay je.